Hi everyone, my name is Doc Dan Saddik and welcome to another episode of 50 Shades of Grey. So today we're going to be looking at an MRI of a right knee. You know it's the right knee because on the lateral side here you have the iliotibial band, and that's the right side of the knee. And it's a patient who's 44-year-old male patient. No history of trauma, just some persistent medial knee pain is the history. Okay, so the first thing I always look at is the menisci. We all have our standard patterns, and I always look at the menisci. Now, the reason why I look at the menisci first, I know other people talk about joint effusions, and sometimes they talk about ligaments first, but the most affected component of the knee really is the meniscus. And that's why I say to the techs as well, whenever a patient is moving and you can only get one sequence from the patient, always do a sagittal PD. You'll note that most people sequences run as PD and PD FATSAT. We call them T2 FATSAT, but in fact, strictly speaking, they're a PD and PT FATSAT in a multiplanar sequences acquired. Okay, so the reason why I want a sagittal PD is because that is the most sensitive sequence for a meniscal tear. The PD fat saturation sequences add sensitivity to the diagnosis, add specificity to the diagnosis, but they are nowhere near as sensitive. Most meniscal tears, as you may or may not know, are picked up on the sagittal PD imaging. Other sequences can pick up the meniscal tear, such as the coronal sequences, but generally, if you had one sequence, it's the sagittal PD to pick up a meniscal tear. Sometimes the meniscal tear may only be seen on a coronal or even just an axial cut, but that's much less common. So let's have a look at this patient's menisci. We'll start off. Here we have the medial meniscus. We normally expect the posterior horn of the medial meniscus to be larger than the anterior horn. And if that's not the case, we have to ask ourselves why. It could be that the patient's had previous surgery. And so what would mark as a previous surgery? Well, as I've said, a smaller meniscus. In this case, there is truncation of the meniscus. This patient could have a history. It could be due to previous surgery. And that's why I always check the notes before reporting a case to see what the patient's written as well, to make sure there is no history of previous surgery. Bear in mind, on the clinician's notes, sometimes they miss that out. So it's important to check the patient's notes as well. Other signs of previous surgery are also changes to Hoffa's fat pad, such as fibrosis and trimming of its posterior margin, but I'll come back to that later. So in this patient, there is no history, you can take it from me, no history of previous surgery. And what do you see here? Well, you see a meniscus which should normally be sharpened here. You can see that it's actually truncated. That is consistent with a radial tear of the meniscus. And there's also this diffuse, ill-defined tearing of the remainder of the medial meniscus as well. As I would say, contacting the infraarticular surface and extending from the inner to the outer third of the meniscus. Interestingly, if you look very closely on the coronal PD, there is also evidence for a flap tear through the body of the medial meniscus. Now, these flap tears with meniscal fragments displaced into the gutter are usually best visualized on the coronal imaging. It's hard to appreciate on the sagittal and usually best visualized on the coronal imaging. And here we have a case here. There's a small meniscal fragment, contiguous meniscus fragment displaced into the medial gutter just inferior to the joint line. So the way I would describe this medial meniscus is as follows. There is a large complex tear of the posterior horn and body of the medial meniscus. It demonstrates a radial component. Stop. In addition, there is a flap tear of the body of the medial meniscus with a 0.2 centimeter meniscal fragment displaced into the medial gutter just inferior to the joint line. Stop. Now that's important. It's important to say this, describe this meniscal fragment. You might say, oh, what does it matter? You've said there's a meniscal tear. Who cares? And often that's the case. Often it doesn't matter. If you say there's a medial meniscal tear, the surgeon will say, look, that's where his pain is, I'm going in. But there's a little bit of a catch here. Sometimes this fragment may not be appreciated. They might dig around for it, probe underneath here and try and push out a fragment, but sometimes it may not be appreciated surgically, and that's why you have to make sure that the surgeon knows about it, because there's no point having a go at this part of the meniscus and trimming it away and then leaving this fragment here, because the patient will still likely be symptomatic. All right, so that's the medial meniscus. What about the lateral meniscus? Let's talk about that. Well, here, the lateral meniscus is a bit different in terms of size to the medial meniscus in that the anterior and posterior horns of the lateral meniscus should be roughly symmetrical in size. Remember, the medial meniscus, the anterior and posterior horns are different in size usually. The anterior horn is usually smaller than the posterior horn, but the lateral meniscus, they should be of equal size. And you can see here that they are of equal size. They look beautiful, they're nice, they're sharp, triangular, they're sharply and triangular in nature. And here it is here on the coronal imaging, beautifully shown, triangular in nature as well. So this lateral meniscus is normal, and that's how I would say, describe it. I'd say the lateral meniscus is intact. The next thing I would go on and describe, I'd look also for perimeniscal cysts before moving on from the menisci, and perimeniscal cysts are best visualized on your, what we will call PD fat saturation imaging. Some people call it T2 fat saturation, and that's fine. And that's important sometimes to say it in the body of the report, T2 fat saturation. So I'd say PD and T2 fat saturation if I give a technique. And the reason why is clinicians understand the term T2. They find it hard to understand the term if you just say PD. They need to hear T2. It's something that they're aware of. And the reason why we look at the T2 with regards to the meniscus as well is because we're looking for a perimeniscal cyst, which this patient doesn't really have evidence for. Okay, so we've dealt with the menisci. Always, the next thing we should discuss is the cartilage. Okay, so is the cartilage intact or not? Now, the cartilage is really open to interpretation. I think if there's anything in orthopedic literature with regards to MRI, the one thing that is subjective or much more subjective than other things is cartilage. What one person might call a bit of a cartilage loss, another person might say, no, the cartilage is fine. I know there are articles in the literature that tell you that the cartilage can be assessed, and they give these 98% to the level of a 98% specificity and sensitivity and accuracy. I don't believe that. I don't think it's possible. Not at this stage. Firstly, because there are several reasons. The cartilage is thin, makes it more difficult to image. The cartilage bends around corners, as you can see here. It goes up the side here, makes it more difficult to image. And sometimes with a lot of the joints, they don't lend themselves to microcoils where you can get even closer to the cartilage. So I don't believe those studies which say we're very, very good at looking at cartilage. The other thing you have to bear in mind about cartilage is this. The cartilage can appear thin in a patient, and you can say, oh, look, you could argue maybe there's minor diffuse chondral thinning of the cartilage. But saying that, often that does not translate arthroscopically. In other words, it may appear thin, but in fact it might be normal for the patient. And when they do an arthroscope, they don't find anything. So I tend to use the term it's either more significant diffuse chondral loss, or I use the term focal chondral loss. So for example, in this patient, we can see that there is chondral loss here. So I would say in this patient, this looks full thickness. Well, it certainly looks of moderate degree. So I would describe this chondral loss as diffuse moderate chondral loss of the peripheral aspect of the medial tibial plateau. The chondral surfaces of the lateral compartment appear grossly preserved. All right, so moving right along now, let's look at the patellofemoral joint. That's the next structure I want to look at.